Thank you very much, Ahmed, primarily to you and also to the host of GIST for allowing us to come here as the Acute Cardiovascular Care Association and join in this session. My slides should be advancing at some point here. So cardiogenic shock, as you see here, we are faced with a really bad situation in these patients with acute myocardial infarction and cardiogenic shock with an unchanged mortality, as you see, about 50 to 60% over several years with no really impact of any interventions we have done. What we have seen in Germany, but also certainly in main Europe, is really a lack of the use of the balloon pump over the years after the publication by my colleague and friend Holger Thiele of the IABP2 trial. Of course, also Uwe, as always, was involved. So you can see here how it has been evolved. These are data up until 2017. I'm sure they have not changed much since. Maybe Impella, as you see at the end, is being used increasingly via ECMO, exploding in use over the past years as balloon pump turned out not to be efficient. However, there was little proof. Now, so you have two competing systems here. You have the Impella that you can use in patients with low output, or you have an ECMO that you can implant, but you have to realize these are two completely different systems here. The Impella being a brief assist, doing mainly unloading of the left ventricle, whereas an ECMO, VA ECMO, is a complete cardiopulmonary replacement system, of course, which is very efficient in patients who also have problems with the ventilation and oxygenation. So lots was expected from the ECLS shock trial, randomizing patients to ECMO routinely in cardiogenic shock versus control. Here you see the results of the control arm published by the duo, Holger Thiele and Uwe Zeimer, last year in the New England Journal of Medicine, and very disappointingly, no effect of routine use of ECMO in these patients. So we didn't have much hope for the Danger Shock trial conducted in Britain, Denmark, and Germany primarily. And it was published earlier this year, so fresh off the press in New England Journal. And you saw here almost 400 patients were randomized in the Danger Shock trial. They were pretty sick, but importantly, these were STEMI patients treated quite early, within 4 hours to the median lactate was 4.5, ejection fraction was low at 25%, and systolic pressure certainly as expected. Importantly, almost 3/4 of the patients had LAD or left main infarct-related artery as the culprit. So directly to the results here, you can see the important pivotal trial showing an all-cause mortality that was significantly less in the patients treated with Impella compared to usual care. What you see is other important features here, that you have an escalation to other MCS of only 15% in the micro axilla flow pump system and 21% in the control group. The median duration was about 2 to 3 days of the support system. Importantly, of the Danger Shock trial, you cannot do this without expenses, and certainly there were more risk and complications in the Impella arm, with twice more the bleeding risk, limb ischemia 5-fold increased, and of course renal replacement therapy was also doubled in the patients for reasons that we do not totally understand until yet. So a couple of subgroups, as you see here in this diagram, you really have a consistent effect across a number of important baseline, sex, age groups, and also arterial pressure, which actually might have a signal. So maybe you have a signal towards the better effect in patients who are really in the lower end of the median or below the median in blood pressure. SCAI did not seem to matter that much. So whether you're in SCAI C or in the worse groups of DNE had about the same effect of the Impella use in these cardiogenic shock patients. So when you compare these two studies, I think it's really important that there are certain differences. As I mentioned earlier, these are not the same. These are not two sort of competing systems for the indication of cardiogenic shock. In DanGer, only STEMI, clear stenents were included. Patients were not allowed to have prolonged CPR. They could have just, one shock from ventricular fibrillation was allowed. And there were no so prolonged out-of-hospital cardiac arrest, and the GSS score was low. The primary endpoint was a 6-month, because many of the patients are actually still hospitalized when you go out to 30 days in their severely ill patients. ECLS shocks allowed all AMICs, and they allowed CPR up to 45 minutes, which actually was the case. 78% of all patients in both groups, conservative and the ECMO group, actually had been resuscitated prior to randomization. And of course, the primary endpoint, as you know, was 30-day all-cause mortality. So again, important differences in interpreting and understanding which patient you should offer these therapies and how to individualize treatment. In ECLS shock, you had actually 38% of the patients in extremis using the SCAI classification of shock, only 18% in DanGer. So it's fair to say that the ECLS shock trial is a more higher risk population where they might already at inclusion or early on in the hospitalization have a very bad prognosis with brain injury before actually profiting from the device and the reperfusion undertaking. As you know, these devices can be combined in patients that have a ballooning of the left ventricle, as you do unloading, either if you do a septostomy, or you can use Impella on top of ECMO, and that is currently, as you see on the right side, being tested in the unload ECMO trial that has almost randomized 100 patients until now. So we'll see the effect of combining these two devices in cardiogenic shock. Mind you that before the enthusiasm grows too high and too hot, that if you look at the eligibility in these trials, if you really look at the inclusion criteria, exclusion criteria on the top, and look at the very top at the IABP Shock 2 trial, the DanGer Shock trial, and the ECLS Shock trial, you can appreciate this is data from the registry, a large German registry. But if you then look at the data below, you can see here that the patients eligible for randomization in these trials are only about 5 to 10% when we're talking about the DanGer Shock trial and the ECLS Shock trial. So very important take-home message. This is not for every shock, and you really need to individualize treatment. So from DanGer Shock, I think there are some important take-home messages. It's a landmark trial, and it's really an important step forward in the clinical care of acute myocardial infarction complicated by a cardiogenic shock. It's the first trial in over 20 years to demonstrate a reduction in mortality with a therapeutic intervention in acute myocardial infarction that were complicated by cardiogenic shock. And some consideration about these high-risk AMI patients with shock and also the DanGer. So this is STEMI only. So these are only fresh STEMI with clear-cut EKG changes, did not include NSTEMI or worsening heart failure, cardiogenic shock. They had a high lactate and a very low median ejection fraction, about 25%. And this is the good news, the mortality was, as expected in the control group, about 60%. But importantly, less than 1/3 had cardiac arrest, and we only had about half in DanGer Shock trial, a contingent of patients that were in shock stage E compared to other trials like the ECLS trial. So with that, I would like to thank you for your attention, and happy to represent the ACVC here of the ESC, and I welcome you to come to our Congress in Florence next year in March. Thank you very much.
Thank you very much.